As we go through life, we sometimes experience an event that is extraordinary in its intensity or severity, or we may have stressors that are beyond the stress we experience in daily life. These events would be expected to disrupt the life of anyone experiencing them, not only those with a mental illness or those at risk for one. Some examples of individual trauma or stress may include a history of abuse, like rape or childhood abuse, illness, such as an MI or a cancer diagnosis, or being the victim of a crime, such as a robbery. Group traumas affect large numbers of people. Examples of this type of trauma include war or a terrorist attack like 9/11, a natural disaster like a tornado, and a community loss, such as the death of a beloved community member. Some characteristic signs of stress and trauma include poor coping, difficulty managing stress, emotional difficulties, difficulty resuming activities of daily life, and other symptoms like anxiety, insomnia, and grief. Most people are able to work through the stressor or trauma and return to their usual level of functioning. However, some people will continue to have problems with coping and may develop a disorder. Some psychiatric problems that are related to trauma and stress are adjustment disorder, depression, complicated grieving, acute stress disorder, post-traumatic stress disorder, and dissociative disorder. Post-traumatic stress disorder, or PTSD, is a disturbing pattern of behavior demonstrated by someone who has experienced, witnessed, or been confronted with a traumatic event such as a natural disaster, combat, or an assault. These patterns of behavior can include intense memories of the trauma, dreams, and nightmares, flashbacks, intense recurrent intrusive thoughts, emotional numbing, increased irritability, and hyperarousal. DSM criteria is in your book, and it's posted in the module for Chapter 13. Some possible causes of PTSD include rape, exposure to combat, childhood neglect or abuse, sexual molestation, physical attack, and being threatened by a weapon. There are three major elements of PTSD. First is re-experiencing the trauma through dreams or recurrent intrusive thoughts. Second is emotional numbing or feeling detached from those around you. And third is experiencing hyperarousal or feeling on guard and irritable. PTSD can occur at any age, including during childhood. Risk factors for developing PTSD include being directly involved in a traumatic event, experiencing physical injury, losing a loved one, not having good social support, and having a previous psychiatric history. Acute stress disorder is very similar to PTSD and shares its signs and symptoms. The big difference in the two is the timeline. Acute stress disorder is an acute disorder. It occurs less than 3 months after the traumatic event, while PTSD occurs after 3 months post-event. PTSD is a chronic condition, while acute stress disorder is acute. If we can treat acute stress disorder early, we can try to prevent it from becoming PTSD. In turn, PTSD can lead to depression, anxiety, and substance abuse. Adjustment disorder is a reaction to a stressful event that causes problems for the person. The most common stressors are financial, relationship, and work-related, and the person will have more than the expected trouble coping with the event. Symptoms will develop within a month and don't last for more than 6 months. At the end of the 6 months, the person will either have adjusted successfully or they will move on to another diagnosis. Treatment is typically outpatient counseling or therapy. Reactive attachment disorder, or RAD, and disinhibited social engagement disorder, or DSED, are both childhood disorders and occur before 5 years old. They're typically a response to childhood abuse or neglect. With RAD, the child exhibits minimal social and emotional responses to others and may appear sad, irritable, or afraid for no apparent reason. These children have not learned to bond with their caregiver or to form meaning relationships with others, and they have trouble managing their emotions. With DSED, the child exhibits unselective socialization. Most children under 5 show a preference for their primary caregiver, but kids with DSED don't. They don't hesitate socializing with strangers. RAD and DSED can be caused by grossly deficient parenting and institutionalization. Adolescents are more likely to develop PTSD than children or adults are. Age, gender, the types of trauma, and repeated trauma are all related to an increased incidence of PTSD in adolescents. Adolescents suffering from PTSD have an increased risk for suicide, substance abuse, poor social support, academic problems, and health concerns. Trauma-focused CBT can help these adolescents and be delivered either at school or in their community. PTSD has been found to be a universal problem and occurring in countries around the world. Those who experience political oppression have been found to have lower levels of resilience and poorer long-term outcomes. People that have a stronger sense of self and a cultural identity are diagnosed with PTSD less frequently and had better long-term outcomes if they were diagnosed with PTSD. There are several options to treat PTSD. One is therapy, which can be either group therapy or individual therapy. Therapy is frequently CBT or cognitive behavioral therapy. Medications can help, and you may see medications like antidepressants, which are SSRIs or SNRIs, or anxiolytics to help with some of the symptoms of PTSD. The patient may also need a sleep aid to help them sleep if they're having trouble sleeping or with nightmares. Gold standard treatment will use both therapy and medications. Exposure therapy helps with the avoidance behavior that comes with PTSD. It helps the person face their troubling thoughts and feelings and to regain some control over them. The person will confront a feared emotion, situation, or thought and use relaxation techniques to help them manage their anxiety about it. Adaptive disclosure is a specialized CBT developed by the military as an intense, specific, short-term therapy for active duty military personnel with PTSD. It incorporates both exposure therapy and the empty chair technique. The empty chair technique is just that. The patient can put anyone they want, alive or dead, in the chair in order to say whatever they need to. Adaptive disclosure is a short 6-session therapy. Cognitive processing therapy uses structured sessions that focus on examining beliefs that are incorrect or that interfere with daily life, things like guilt or self-blame. It's been used successfully with rape survivors and combat victims. PTSD is usually treated on an outpatient basis unless the person is suicidal or is unable to function effectively in their life. Dissociation is a subconscious defense mechanism that helps a person protect their emotional selves from recognizing the full effects of a horrific or traumatic event by allowing the mind to forget or remove itself from the painful situation or memory. Dissociative disorders are a disruption in the usually integrated functions of consciousness, memory, identity, or environmental perceptions. Dissociation is a defense mechanism that is used involuntarily. Dissociative disorders frequently interfere with a person's relationships, their ability to function in daily life, and their ability to cope with the realities of an abusive or a traumatic event. Dissociation will vary in intensity from person to person. Onset can be sudden or gradual, and it can be transient or chronic. Those with PTSD may experience dissociative symptoms. There are 3 main types of dissociative disorders. First is dissociative amnesia. With this, the person can't remember any personal information. In fact, they may have a fugue experience where they suddenly move to a new place and can't remember anything from the past. They usually take on a new identity as well. Dissociative identity disorder, or DID, used to be known as multiple personality disorder. With this, the person has two or more distinct identities or personalities that can take control of their behavior. They're also unable to recall personal information. Psychiatrists debate whether or not DID is a legitimate diagnosis. One day we were talking about DID and treatment team, and no one there had actually seen a case of it personally. With depersonalization, derealization disorder, the person has a persistent or recurrent feeling of being detached from their body or the sensation of being in a dreamlike state. These patients are not psychotic or out of touch with reality. Dissociative disorders are pretty rare in the general population, but are far more prevalent in those with a history of childhood abuse. Some people with PTSD or dissociative disorders will repress memories. Repressed memories are memories that are buried in the subconscious or repressed because they're too painful for the victim to acknowledge. Treatment for dissociative disorders includes therapy, either group or individual. Therapy will focus on reassociation or putting the consciousness back together. Medications may be prescribed to treat symptoms like depression or anxiety. Goals of therapy include improving the quality of life, improving functional ability, and reducing symptoms. When assessing a patient with a trauma or stressor-related disorder, be sure to look and see if the patient has a history of trauma or abuse, whether it's from childhood or a current relationship. Observe their appearance. Are they hyper-alert and reacting to any noise? Do they seem uncomfortable, anxious, or agitated? Are they having trouble staying still and need to pace? There are a wide range of moods possible. The patient can be passive, agitated, or anywhere in between. If they're having a flashback, the patient may seem scared, cry, scream, or try and run and hide. If they're dissociating, the patient may sound different or stare vacantly. They may say they feel a lot of internal rage or that they feel dead inside. Thought process and content. Patients may talk about having nightmares, flashbacks, or recurrent intrusive thoughts. They may report hallucinations, self-destructive thoughts, or suicidal ideation. This can interfere with their ability to focus on other things and daily living. Patients with trauma or stress disorders are generally oriented to reality unless they're dissociating or having a flashback. At these times, the patient may not respond to the nurse at all. Patients may also have memory gaps due to abuse or trauma. These patients frequently report trouble with relationships and roles. They may struggle with authority figures and thus have trouble at work. Close relationships may suffer if they're unable to trust others. They may be estranged from family or quit their job. They may feel unable to socialize with others. Physiologic concerns include sleep, appetite, and substance use. Patients may have trouble sleeping due to nightmares. They may either overeat or have a lack of appetite. Some will use alcohol and other drugs to try and help them sleep or to block out the intrusive thoughts. Some nursing diagnoses you may see include risk for suicide or self-mutilation, ineffective coping, post-trauma syndrome, powerlessness, chronic low self-esteem, and risk for self or other directed violence. Some related diagnoses can include anxiety, fear, disturbed sensory perception, sleep deprivation or disturbed sleep pattern, sexual dysfunction, spiritual distress, and social isolation. With our nursing interventions and outcomes, we need to focus on improving the patient's self-esteem and promoting empowerment. Outcomes can include the patient will be physically safe, the patient will demonstrate healthy, effective ways of dealing with stress, or the patient will express emotions in a non-destructive manner. Interventions can include referring to the patient as a survivor and not a victim, help them to identify flashback triggers, encourage them to journal their feelings, and teach them to use distractions and relaxation techniques. Grounding techniques help the patient realize they're in the present and are safe. It's important to validate the person's feelings by saying things like, I know what you feel is scary, but you're safe now. Grounding uses the five senses to diminish a dissociative experience by focusing on what they're experiencing now. Techniques include telling the patient who you are, remind them where they are, have them look around and identify 3 things they can see, 3 things they can touch, and 3 things they can hear. Remember to stay calm and don't touch the patient. If they're having a flashback, they may lash out reflexively. As nurses, we need to deal with our own personal feelings in order to care for those who have experienced a traumatic event, which can be horrific. If you as the nurse are overwhelmed by the violence or death that has occurred, it will confirm the patient's feelings of being victimized or traumatized. We need to convey empathy and validate the person's feelings while remaining calm, caring, and professional. We need to be supportive and non-judgmental towards our patient. If we've had to deal with a traumatic event ourselves, we may need to talk to a counselor in order to properly care for our patient.